Topbed Talk.
Well, I hope as we go into this next session, which is a Massimo lecture, Patient Safety, how do you make the changes that change culture? We're going to introduce our special guest related to that in a moment. I'm hoping, first of all, I can be joined by our co-host, Sol Aronson from the USA. Sol, are you there?
Thank you, everybody. So, of course, Dr. Mike Ramsey, who's the current chair of the Department of Anesthesia and Pain Management at the Baylor University Medical Center in Dallas, is also probably, for purposes of this meeting, wishing for us to introduce him more as the board chair of the Patient Safety Movement Foundation. We're joined also with Dr. Fleisher, who we met earlier, who is now the CMO and director for the Center of Clinical Standards and Quality for the Centers of Medicare and Medicaid. Thank you, Lee. You're going to be speaking to us today as a provider and a person with a strong opinion, but not necessarily one that is reflective of CMS, and I will let you speak to that, I know. Sarah Lenz is the Senior Vice President for Policy, Research, and International Affairs for the AARP. She also is a policy wonk, if you will, but will be speaking to us as much as a policy expert as a patient advocate for the senior population. And Lili Brillstein, who's a dear friend from years ago, who I was fortunate enough to meet at our first EBPOM meeting, comes with us with a great experience and background from the payer side. She worked really as the author, the sort of architect of the value-based episodic care in Horizons Blue Cross Blue Shield, and is now the CEO of B Collaborative. So welcome, everybody. Mike, during the playing of your pre-recorded video, we had an opportunity to sort of speak amongst ourselves in private, and you raised, I thought, a very interesting question that I'm going to ask you to repeat now for the purposes of kicking us off.
Sure. What can we do to reduce harm in our hospital? Nobody goes into hospital expecting to get hurt. None of the caregivers intentionally harm patients, but patients do come to harm, and unfortunately some patients even die as a result of the treatment or care they receive in our hospital. So how do we tighten it all up? How do we make it every hospital you go into has got a safety culture? Every hospital you go into is a high reliability organization. How do we stop each hospital hurting patients in the same way, well reported, but not really hardwired into the hospital system, in the same way that every other hospital has hurt somebody? How do we communicate all these errors that occur or poor practices that occur and let everybody know clearly what's happened? How do we stop them being kept quiet? How do we stop them being even hidden or denied, so that even people in the same hospital have no idea that a major error occurred or a major practice occurred? And so what I was thinking of this early on at the start is maybe we need something like a National Patient Safety Board, that an independent group of experts who look at each major error and major harm and come up with a solution that is broadcast to all our healthcare systems. So that's just a sort of opening gambit to maybe get some conversation going.
A lot to unravel there. And I'm going to ask that we speak to the impact that might mean to us through the lens of, if you will, the patient or the provider or the payer. Lili, your perspective through the lens of a payer?
Yeah, so thank you. I would say, there's the move or the movement actually from fee-for-service to into value-based care models, where we take our focus off of incremental units of care and cost of care, which has resulted in incredible amounts of disconnected, disjointed care. And we move towards value, where it's really about creating collaborative models across the continuum that addresses variations in care and in cost of care. It is, I think, it really has patient safety at its core, right? These are models that are really around creating accountability to the patient, leveraging the expertise of all the various stakeholders who are engaged, not just the doc who renders, one particular service, but how do we actually put together protocols that connect all of the care that a patient is getting, reduce the variations, as Mike was talking about, and really optimize both. And I've seen in value models where we focus on outcomes and really build partnership models to address that and to get the very best outcome is a huge step, I think, in the right direction in terms of how the payers can engage and how the construct might be set up from a payer perspective.
Can you incent safety through a payer behavior or motivation or, if you will, factor?
So, I think the issue is more how do we actually create standards of optimal care? And I think, again, in fee-for-service, the focus is really on the rendering of care by one particular provider. And when we look at these collaborative models, it's really about, let's look at the whole picture. Let's look at everything that's happening for the patient in this particular scenario. And let's look at the variations and create clinical protocols that actually address that. So I think yes, I think the payer has some significant ability to help support providers by sharing longitudinal data, right, which they typically can't see. They only see the data that reflects the care they render, to support the providers in building those protocols that create optimized care and the greatest safety, I think, for the patients.
Sarah, how do patients manage or understand or deal with the question of safety? You get sick, you go see a physician, a provider, a healthcare system. You sometimes have to go to the hospital. You expect that's going to be okay and that everybody's going to work toward making you better. Where does safety come into the mix through the lens of a patient?
Yeah, I think it's a great question. I think that patients truly don't understand the breadth and scope of the problem, and it's hard to get your mind around it. The statistic that the number of patients who die each year from hospital errors is equal to 4 jumbo jets crashing each week is one way that you try to describe it. But people simply don't expect that they're going to have an adverse outcome when they come to a hospital or to a healthcare facility. I think driving awareness that mistakes happen and that not only is the healthcare system responsible for it, but that patients themselves need to take some action to help protect themselves is part of the equation here. I think the systematic changes of the Patient Safety Foundation is after and other efforts are hugely important. But I think we've got to get consumer demand to help drive some of these changes, along with AARP, for example, is, we have 38 million members and we try to educate our members, but we try to do things like tell them to bring in checklists and patient advocates. Now, that, of course, doesn't work in an environment like COVID when you're not allowed to bring in patient advocates or visitors. But it has to be a much more deliberate approach, and Mike's suggestion could be a very good one. I know that we've tried penalties. CMS, for example, has penalized hospitals under the Affordable Care Act for some of these errors, 1% of pay. I don't know yet how effective that has been in changing behavior. But before we officially started, I think there was agreement amongst all of us that culture change is going to be critical to this at all levels of a healthcare provision, not just the docs, not just the nurses, but everybody in the hospital has to change their culture in order to make success at getting at the problem.
Lee, I'm going to invite you to speak to this as a provider and a person with great breadth of knowledge, but as a civilian person with great breadth of knowledge. But through the lens of a provider, you're in the foxhole. You're at the ground level. What do you see that we do, and what do you see that we should do, and how do we change?
So it's a really good question, and I will thank you for allowing me not to speak as the CMO of CMS, but at the same time, I think that Sarah has mentioned that penalties don't work. Well, I'll speak a little bit as a researcher in that when we start to look at this question, we know that the checklist only worked in certain places. Like in Ontario, it didn't work, and it only worked in certain hospitals. So while I think that the apps are an excellent place to start, it still will not, in my mind, get us to zero harm until, first of all, unfortunately, accidents happen, and there's a lot of history of that. But we did some studies with our residents when mistakes happen, and we asked them to debrief. And they actually didn't have the capability to debrief without the accident. We actually saw that they couldn't handle how the change in the narrative about what happened, that they weren't willing to go there and talk to somebody. And I think a lot about psychological safety. And Amy Edmondson, who talks in a high accountability, so this high reliability organizations, where you have high accountability and high psychological safety. If you make a mistake, to her, that's the place of learning. But I'm not sure we're yet ready to learn. So that may be a long-winded saying that I do think it's about culture. I think that, but it's a willingness, and I think it's hard for people in medicine to actually begin to change the culture enough to indoctrinate some of the best practices.
I have an expression: between data and change is reality. And what I mean by reality is culture, emotion, trust, making it easy to do. And then until you get over those sort of humps of reality, however great the evidence or data is, change won't likely happen. Mike, I'm going to invite you into this discussion because one of the things that Sarah said that really struck me about patient contribution to the deliverable of safety is I think often we live in a world where there's a perception that if you are out there in the real world, in the ambulatory world, walking and talking and chewing gum, and you get sick, and sometimes that means your sickness requires surgical intervention, which is the focus of this perioperative conference, that the perception is you then will have surgery and you will get better. But there's a big gap in the sense that you need to get healthy enough to tolerate the perturbation of surgery. And so there's a need to have the patient be their own advocate and to be involved in their own advocacy. How do we close that gap?
I think that's a good question again, and I think it's very hard. The patient's emotionally involved because it's them, and they need somebody else with them, as was just mentioned. Really, the patient needs to bring the patient advocate with them if they can, which is a family member or a good friend or an associate of some kind, to ask the tough questions that they're a little bit intimidated to ask, to challenge the caregiver in terms of if it's something simple like, you didn't wash your hands when you just came in to see me. Things like that. Or, what is the real risk of this surgery? What could happen? And ask those right questions that when you're listening, it's you and you're kind of numbed with the fact that you're sick anyway. I don't think you're in the right state of mind to ask the right questions. So once this COVID is over, we need somebody, we need patient advocates to come in with the patients and have the list of questions. Maybe we can give them some key pointers of things they should be watching out for.
So it's an interesting thing because you actually started the question, Saul, and then Sarah and I have been talking about this a lot. They assume they're getting better, but there's a lot of people who have surgery that actually don't get better. In fact, COVID's going to ask the whole question of, did all this delayed care actually make a difference in people's lives? Clearly it will in many, but it may actually improve in others. We don't know the data yet. So there's actually two parts. One is, should they even be in the hospital in the first place? And Sarah and I talk about that from the geriatric patient. Is this the right thing to do? So,
and what it's a great point. I think as this goes on, we will tease that out. On the other end, the people who are not able to get into the hospital because there's a constraint, or there had been in bed availabilities, we should be taking advantage, I would argue, of this time to really get them optimized so that they are ready for surgery. Lili, through the perspective of the payer, if I could kind of put you back into that box, and I don't mean to put you into that box, sometimes surgery just simply ain't the right answer. How does that get managed? How does that get sort of turned through the mix, if you will?
That is a really good question, actually. And I think, the model that I have worked on, right, is most often is in specialty care, value-based models. And often those models are set up really to address the care and cost of care of individuals who wind up with surgery or wind up in the episode. They have a particular diagnosis, healthcare event, or procedure. And typically they're not designed to sort of ascertain whether the individual actually needed to have the surgery in the first place. So many of the models that I happen to really love the messy stuff and getting in and trying to answer some of those questions. And so I've built models where we start earlier. We don't start with the presumption that surgery is required. We start with some sort of proxy for the symptoms or the whatever the issue is, and then watch the patient and create incentives or a construct that actually incentivize all of the potential provider partners to make the best clinical decision, make and reward for the best clinical decision. So it may actually be better for a patient not to have surgery, and they may not need invasive treatments. They may need some other sorts of care for which under fee-for-service the providers might get paid less, but under a value model, when we look at outcomes, might be a much better outcome for the patient and for the providers.
Monty and Mike, how do the healthcare systems in the UK deal with this very, I would guess, ubiquitous question?
I think over the years things have got better. I agree that penalising does not help. I think openness and accepting the fact that mistakes do happen and we should do everything to try and prevent that is very, very important. Now, one thing that changed relatively recently is the requirement for us with complete candor to communicate with patients, even if we expose them to something that didn't result in harm, but could have resulted in harm. And I'll get Mike's views on this as to whether he thinks that transition, that we are duty bound to personally communicate to a patient, even if we just pulled back before we injected the wrong thing in the wrong place, or we stopped before we were about to cut off, the wrong side, if you see what I mean. That makes you think a lot harder from the point of view of where we stand. I don't know, do you have an impression as to whether that's made a difference, Mike?
I think it's engendered something of a culture change, and I think it's predominantly been good. And it's certainly been, it's good to keep us honest that we, when there is harm, that we share that and we make it clear that we're doing our best to provide a remedy and do the root cause analysis and all those kind of things. Where I'm less convinced, and partly from direct personal experience, not personal error, thankfully, but is where the near misses. If you start being very candid about near misses, actually you're just causing distress in a patient who hasn't been harmed, and I'm not sure that aspect of it is positive. We do. How effective it is up for discussion, but we do effectively have a sort of national patient safety board in the UK, and we have an individual who's the patient czar, for want of a better term. So his responsibility within NHS England is to oversee investigations and systematic safety problems. So we're a little bit of a way down that journey.
Bad stuff still happens.
Yeah.
I've always assumed, and it might be a false assumption, obviously safety is complex, but I've always worked with the construct that some of the errors, if you will, were tethered to production pressures. We, work and play in a tough sandbox. Culturally, is there a difference in our system between the NHS and what we currently are sort of evolving from and to in the U.S.? I'm going to invite Mike and Lee and Monty and Mike to speak to that, as well as anybody else.
I think we made a transition through my career in medicine from safety always comes first to the internal market saying we need to get on with this. So I think we weakened some of our systems from that perspective. Sorry, Mike Ramsey.
No, I think you're right. There's great production pressure put on us in the U.S. Turnover times, critical times from anesthesia's point of view, when a patient's going to go to sleep or a patient's going to wake up, and you're on, that took 10 minutes. We've got to get that down. That's ridiculous. You've got to take the best care of the patient. And so that's the battle I fight a lot. You can still be very efficient, but you've got to be safe. And that's the important thing, not the number of minutes. And that's part of the U.S. system. But there are lots of things. Right now, in our drug box in the OR, we have a drug called ephedrine in a 1 cc ampule that is identical in look and like to a drug called epinephrine. One will kill you if you inject a cc, the other one won't. That's dangerous. That should never happen. And yet suddenly that's appeared in our drug boxes, and I know someone's going to make that mistake, so I'm fighting to get it taken out. But that should never happen. There are lots of things. They're just a couple of small examples of things that we allow to happen, and it comes from everywhere. That ought to be stopped, but it's going to take it's not easy to stop. It's just multifactorial.
It puts me in mind of a story I've recently heard in Baltimore. There's a nursing facility where they have a very high African-American population in a poor part of Baltimore. And they've had stunningly good results in COVID because the administrator a while back made a relatively controversial decision to have an infection control officer in that nursing facility from the very beginning. So you're talking about production and the pressures in the hospital setting. But if there are people whose job it is to enforce appropriate behavior, will that help?
Good question. I would ask Lili to weigh in on why are we, I struggle with this. It's a philosophic sort of question. We reward production. Clearly, our system is built to recognize and therefore reward production. Mike, turnover times equals, production efficiency, et cetera, et cetera. But we don't reward good behavior. And so it's hard to incent good behavior when there just simply isn't rewards to recognize good behavior.
So I think,
Sarah, you mentioned somebody policing good behavior, but we aren't rewarding good behavior.
Mm-hmm. So I think, again, that's sort of the move away from fee-for-service, where it is about production, how much can you do, how fast can you do it, and create this, what Sarah was talking about, this sort of culture change where it's really about collaboration and partnership along the spectrum of care and across the table with payers as well, and create models that focus on how to, often payers and providers negotiate contracts, and I've been in plenty of those negotiations, and it's all sort of adversarial and fighting, and frankly, the patient never comes up. There's never discussion about the patient. There is negotiation around units of care and unit costs, and I would suggest that there are lots of people in that room who have absolutely no idea what they're negotiating, how it impacts patients. in these models that we're seeing now, patient-centered medical homes, specialty care medical homes, episodes of care and ACOs, the focus really now is on patient outcomes and rewarding. So it's, Saul, you ask about, behavior. And to me, that's about the process part, which I think, Mike, is a lot of what you're talking about. From the payer perspective, what they're really looking for overall is predictability of cost, right? That's sort of the primary motivator for the payer. And their focus in building these models really needs to be on patient outcomes that allows the various providers in the continuum to focus on what behavior do they need to actually perform or do to really get to the very best outcomes. And I think as we begin to see more models that focus on a different kind of culture, partnership, collaboration, communication across the continuum, and establishing and allowing the providers and supporting the providers in establishing protocols that get to the best outcomes, I think we'll begin to see some changes.
Lee, by the way, great discussion, everybody. Unfortunately, I think we're running into that end of the hour. Lee, closing comments?
Yeah, no, I think that's a really good thing, but it's not always the external pressures, and COVID is an example of the internal pressures. And, looking at people rushing to try to do more because they want to take care of more patients. And when we had sick patients in our ICU and they needed to be intubated, you had people feeling the need to go in as quickly as possible, but they could make a mistake in donning and doffing. And you have in nursing homes, and Sarah's example, as people are getting sick, people wanting to take care of more people, and that stretches us. And there's a lot of work showing about staffing. So it's not just the external pressures, but our own internal pressures of not slowing down and taking the time because of our own need to take care of patients. So I think we need to give ourselves permission sometimes to say we can do better by thinking, and that gets, to Mike, that extra minute ourselves when we do things. It actually may be, in the end, much safer for the patient.
It's a very, very good point. I'm sure most of our listeners are too young to remember, but when I was an intern, that's taken us back many decades. Remember the book House of God, and I recall a passage that said, during a code, the first pulse you should take is your own. Monty, any parting words for this discussion, which I think is, it speaks to itself. Just super. Thank you, everybody.
Be safe out there.
On behalf of EBPOM 2020, Chicago Virtual, I thank you all. I thank all of the participants throughout the day, and certainly to this very prestigious panel. What a great way to end the first day session. Thank you, everybody. Be safe.
Top Med Talk. Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.